All right, there you go.
Thanks, Karen. So good morning, everyone. This is RAC number 9 for HB 3046, Mental Health Parity. My name's Brooke Hall, and I am a Senior Health Policy Analyst with the Department of Financial Regulation, and I'll be leading the RAC for today. You should have received an agenda and materials for today's meeting via email. Just so you know, the plan for today is to continue reviewing the draft rule from where we left off at the last RAC meeting. And if time allows, we will review the changes that have been made to the draft rule since the last meeting. And we are going to start off with some comments that have been sent to us since the last RAC. But before we get started, does anyone have any questions? All right, hearing none, we'll go ahead and provide an overview of the comments that have been provided. We did receive 2 comments since the last RAC, one from OIMHP and one from NAMI. So OIMHP, do you want to go first?
Sure. My name is Melissa Todd. I'm a psychologist in private practice in Eugene, and I'm here representing the Oregon Independent Mental Health Professionals. Generally, we just, support all of the steps being taken through HB 3046 and believe that those steps are going to contribute to network adequacy. We've been saying this for a long time that from the practitioner standpoint, the biggest barriers to serving on insurance network panels have been aggressive utilization management practices, as well as suppression of reimbursement rates, particularly those for CPT code 90837. Those are being addressed in the bill, and we really see those as great steps toward creating more robust insurance networks. And then further, we just gave really specific suggestions on adding rule language throughout section 836.053.1405. And the general intention behind all of our suggestions were to sort of tighten things up and close possible loopholes. We feel really encouraged about the steps being taken from as a result of HB 3046, and we just want to make sure that the rules are written in such a way that do not allow for loopholes that we end up having to address later on.
Right. Thanks, Melissa. And Chris from NAMI, would you like to go next?
Sure. I mean, I think our comments are self-explanatory, so I'll just leave it at that. I mean, they're brief, and unless you need me to summarize them.
Nope, feel free if you'd like to, but if not, that's fine. They are included, or they were included in the email sent out with the agenda and the draft rule. So if anybody would like to review, you do have both sets of comments. All right, so now we're going to continue the review of the draft rule. I believe that at the last RAC, we left off reviewing the 1405 rule at what is now number 10. So if you could pull up the rule and go to 1405.10, we can start the review from there.
Let me know if I've got the right one up.
It's almost at the bottom, Karen.
Okay, thank you.
So let's see where we are. Yep, there's 1405. And if you just go down a little bit more, we're starting at number 10.
Okay.
There we go. So this is where we left off at the last RAC meeting. And this number 10 outlines requirements for level of care placement and follows statutory language. We did add 10D big A through D, which outlines which criteria and guidelines from nonprofit professional associations are considered compliant with the rule. So does anybody have any questions or comments about this section?
One comment is that I wonder if we want to include the locus for addictions, because it is a nonprofit specialty organization, and it does address addictions as well as general behavioral health level of care.
Okay. I'm taking note of that. And I saw a bunch of hands go up at the same time. So why don't we start with Jen Baker, and then we'll go to Gary and Melissa.
Okay, so we have concerns about the newly added language where if you could scroll up where it does say for non-level of care placement, other criteria utilized are subject to review and approval by the department or its designee. Where in the statute does the DFR have authority to enter that into the rule?
I would have to review and look specifically for that. I don't know that I have.
Well, spoiler alert, it doesn't. So, I mean, we definitely need that language to be removed because the DFR, I mean, is not qualified to make those kind of clinical level decisions, and it is very concerning. And if this language it stays in the rule and the DFR starts doing these kinds of reviews, then you are opening yourselves up to a potential court case that could throw the entire law based on Hillman up into question because you're deferring to outside resources outside the state with the nonprofit criteria. So I would highly recommend that that language be removed and the review is allowed to be between the carrier and the provider. And then if there's a disagreement, that they go through the proper appeal system. Okay.
I appreciate that comment. Just for clarity's sake, we were looking into whether we could do some kind of interagency agreement with OHA to review the criteria, or whether we could use.
You're going to need to pass legislation to do that. Like, again, we don't have the granting authority to do that, and we'll submit comments on this, but we're going into dangerous territory here that could have repercussions to the entire legislation.
All right. Thanks, Jen.
Mm-hmm.
Gary? You're on mute, Gary.
Okay, how's that?
Better.
Better. Okay, thank you. Just about three things here. First, agree with Jen that has a little concerned about the division coming in and approving. We didn't know where that came from. Under sub B, above that, it would caught us off guard a little bit. Effective January 1st, 2023. We have no way of knowing what that is right now. And so there's some concerns that we don't know what's going to be approved on that date. So we're not sure how that date came into play or where it came about from. So that was a concern to us. And then additionally, under subsection 10, little a, the word "and" is there. We think that gets more restrictive than what the bill allowed. The bill does allow, the generally accepted standards of care, the levels of the nonprofit professional association can be there, but there's also the ability that we can use in the bill. It allows us to develop our own guidelines in accordance with current generally accepted standards of care. And so it's one of those things of being limited to just the nonprofit professional association criteria. We don't think the bill, and we don't see where the bill gets that limited. And we think it's not good. The market needs to be able to have flexibility as long as they can defend or present evidence to the commissioner that, hey, what we're doing is in alignment, and not just be tied to just the nonprofit professional association. And that's it.
Thank you, Gary. I know there was a question about the "and" or during the last RAC as well, so I will make note of that and look into that as well. Melissa.
Yeah, we as far as the yellow highlighted section, I had a couple of questions. One, it appears that as it's written right now, this only applies to level of care placement decisions since it's under number 10, and wanted to clarify if, and I know there's some things that we're wanting to figure out about that statement, but wanting to clarify if that could also be applied to non-level of care placement decisions if it is decided that it's something that can stay in the rules. So I just wanted to point that out, that as it's written, it appears to only apply to level of care placement decisions. And if it stays, we would like to see it also apply to non-level of care placement decisions. And then the other piece, we're definitely going to look into this and look at the bill, but, a whole section of the bill was designated to asking insurers to report on their own compliance with this bill and other aspects of mental health parity and Oregon law. And so, I go back to the intention of this bill, trying to create a situation where we're being proactive and making sure that the practices that are being put in place are compliant, rather than being reactive and waiting until some person discovers that something is not compliant and then has to make a complaint about it. That's the way that it's been in the past, and it really hasn't been effective in preventing practices from occurring that are questionable to non-compliant. So this is just something that we are still in support of and would like to examine the bill to see if there's a way to keep this in or to make it part of the reporting requirements.
Thank you, Melissa. Let's go to Rachel next.
Thanks, Brooke. I just wanted to be really clear about what the bill does in response to Gary's comment. If you look at page 17 of the bill, what it says is that for utilization review purposes, decisions must be based on generally accepted standards of care. And then specifically for level of care related placement decisions, those need to be based on nonprofit professional associations. The flexibility comes in when we're talking about all other utilization management related decisions not related to level of care. The section gets a little smushed together. So I just want to be really clear that carriers only have flexibility around other decisions that aren't related to level of care, but level of care related decisions must be based on the most recent versions of level of care placement criteria developed by nonprofit professional associations. Sorry to be a stickler. I just spent a really long time negotiating this specific piece of language, and I really want to be clear around what this bill allows for.
Thanks, Emery. So where on page 17? Because I didn't see any amendments there.
So it's page 17, section 5. The amendment language comes in on C. So what the bill originally did, it sort of lumped everything together, and then the amendment parses out the difference between level of care placement decisions and medical necessity utilization or other clinical review conducted not related to level of care. Does that help, Gary?
Well, what I'm looking at, because under that same, under the section, I look at page 19, where there was new language added under subsection 5. And it says medical necessity, utilization, or clinical review for treatment of behavioral.
What version of the bill are you looking at? I'm looking at the enrolled version, if that's helpful.
Yeah, I'm looking at the engrossed.
Okay.
And it's the bolded language starting on line 20.
Of page
19.
Okay, hold on. I think I'm looking at, okay, you're looking at B engrossed.
Yeah.
Page, sorry.
I'm trying not to sidetrack, but I just want to make sure I'm on the same page.
Yeah, so you're looking at
5A.
5A, any medical necessity.
I think we're going to pull up a copy of the bill as well so that everyone can see it.
Right, so it's in general, medical necessity utilization or other clinical review needs to be based on the generally accepted standards of care. And then specifically for level of care placement decisions, you need to use the most recent version of nonprofit developed criteria. And then for all other related decisions, you can use other criteria so long as it's based on generally accepted standards of care, which include valid evidence-based sources, blah, 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 blah. So the specificity and the very clear requirement is around level of care placement related decisions.
Okay, I'm not getting there, but I can see where you are a little bit.
Okay.
All right, thank you.
I would encourage you to also reference the comments from Representative Nose, which reflect the legislative intent of that section. And then I also welcome you to talk to Kaiser, who are the folks that I negotiated this language with, specifically Amy Favre, who I hope are also very clear, because when I tell you that we spent hours talking about this section of the bill, I'm not underestimating that.
Okay.
Thanks,
Thank you.
Gary.
Yeah, just jump in. I was also intimately involved in those negotiations, and Rachel's characterization of that is correct.
Okay, thank you.
Thanks, Dan.
All right. Thank you, Rachel. So I think next we'll go to Chris, and then Dan, and then Antoinette.
Well, I think Rachel addressed most of my comment, which was the bill is absolutely clear on level of placement, what those instruments are. To the draft rule, in terms of whether the division reviews criteria, I think there's some confusion in some comments as to whether we're talking, there's a distinction between level of placement and then the other utilization management. So to the point of level of placement and reviewing criteria in advance, in the unlikely event that there isn't nonprofit criteria, if the division is unable to review in advance, there must be some pathway other than a dispute between a provider and the carrier for the division to regulate whether or not plans are using criteria that meet the definition of generally accepted standards of care. So I would hope rule or something would reflect that, whether it's prior review or some way to raise that issue to the division. I would think the division has authority, even with case law, to enforce the law and make evaluation of whether carriers are complying with the law. And the law is pretty specific that criteria must, in absence of nonprofit criteria for level of placement decisions in particular, they have to meet the generally accepted standards of care.
Great, thank you. And I think I said we'd go to Dan next.
Thanks. I'll try to keep my thoughts organized here. So first of all, just want to reiterate that I do agree with what how Rachel characterized that we're bound by the nonprofit criteria for levels of care. We're not bound by those, but we're bound by the more general concept, generally accepted standards of care for utilization management, not related to level of care. I'll also reiterate my concern that we're potentially headed for the train going off the tracks in terms of the disconnect between the commercial insurance industry being required to use the locus, CalLocus, et cetera, beginning January 1st, and the provider community potentially being unprepared to provide information in the format that would allow us to use those in a meaningful way. Maybe I'm wrong, maybe I'm catastrophizing and it's not going to be a problem, but I want to, and I welcome it, any perspectives that would talk me down from the ledge there. Also agree with other comments that subject to review and approval by the department or its designee is very problematic. And that, to Melissa's concern about the parts not related to level of care in the rule, we have subsection 8 and 9 that talk about not related to level of play, not related to level of care placement. So that is addressed there as well.
Right. Thank you, Dan. Antoinette? And I think we can pull the rule back up as well.
Great. Yeah, my question pertained again to 5A B in reference to using the most recent version of the levels of care placement criteria developed by the nonprofit professional association for the relevant clinical specialty. I was just curious, in this area, could they be more than one nonprofit professional association? Where I guess we have the flexibility to use either one, or is it just one nonprofit professional association? I was just very curious in terms of what that really meant.
Are you asking if insurers have the ability to use more than one nonprofit
Correct.
association for a particular?
Yes, clinical
Okay.
specialty.
If you scroll down in the A through D, it does list the criteria. Let's see, it says what the nonprofit association is and then what the criteria is used for. So if there is a situation where my understanding would be if there's a situation where you're using, you have a criteria utilized for substance abuse disorder and mental health diagnosis, you would be able to use the ASAM criteria because that is substance abuse disorder, and then also the locus because that's around mental health diagnosis in adults 19 and older. Does anybody else have any thoughts about that?
Those are currently the only tools really available. So there aren't competing nonprofit. This is Chris. They're not competing nonprofit specialty associations. In the future, might there be? I mean, that's a future state question that is unknown.
Well, I would jump in here and say that with addictions, you could argue that the locus is applicable. So there are two there. That's the only time there's more than one that I'm aware of.
Okay, I hope that answered your question. If it didn't, please let me know. Let's see, I see Jennifer, Rachel, and Bennett. So let's go to Jennifer. And we're going to have to move on here soon. I know we've spent quite a lot of time on this section.
Thanks, Brooke. I do want to say this is probably the biggest point of contention, so it's probably good to have this dialogue right now.
Yes.
I just want to reiterate, I agree with what Dan had mentioned in terms of providers being ready to engage in these systems, but I'll let his comment also speak for itself. So the reporting requirements in this bill, the report that we just did, I mean, it's very extensive. It's a very stringent review of our NQTL analysis. So, I mean, the bill itself is the proactivity. It is, we don't need to be more proactive. So let's let the DFR do their job and review those reports and see if they find anything, because that's when you're going to discover if there's going to be a need for change. But again, like adding language that you don't have granting authority for is going to be much more problematic for the results of this bill. So let's let the bill and do the work that it's meant to do, and I'll let the DFR review our reporting to see if there's a problem. That is my concern here. I don't think there's a need to be more proactive than we're already being. That's what this legislation has done.
Great. Thanks, Jennifer. And Rachel?
Thanks. I just wanted to, from the provider side, quickly acknowledge both Dan and Jen's concerns about providers not being ready or not knowledgeable on these tools that carriers are required to use. And I'd love to know if we should have a conversation as this this RAC about, is that a matter of training that the division puts on? Is that something where providers work with carriers? This bill goes into effect sooner rather than later, and I want to make sure it's workable. So if we need to have a conversation around how this gets implemented with our providers, speaking at least on behalf of my clients, not that they do level of care placement, but I'm happy to work with carriers on what that would look like.
Thank you, Rachel. All right, and I see Bennett.
Yes, I just wanted to follow up on Dan's comment as well. I'm involved in the implementation of a project to utilize the ASAM criteria and utilization management for residential treatment. And the number of approvals is extraordinarily low because providers simply can't do it. If you implement ASAM the way ASAM says it should be done, without a lot of training, you're going to have a lot of denials. I mean, 75, 80% or more would be my guess. Because ASAM not only speaks to what we would generally think about as a level of care determination, but it also specifically talks about denying levels of care when treatment plans aren't ASAM compliant. And so there's a real there. I think, Dan, you're absolutely right. That I don't know who should address that, but it needs to be addressed or it's going to be a mess.
All right, thank you. And I see Melissa, your hand is up.
Yeah, I just have a question. I agree with Jen that the reporting requirements are extensive, and so the question that I have is when an insurance company decides to use other criteria, particularly if they're bringing in a third-party contracted company to that develops these other criteria, or maybe they're developed in-house, is that included in the Section 2 reporting requirements? Is that already included? Do they have to, for instance, put that in their report? Do they have to show how it's medically necessary, how it's been developed using evidentiary standards? Do they have to show that they're applying, the other criteria no more stringently to behavioral health than they are to medical surgical? That's a clarification that I would like to know, because if it's already in there, then great. But it just seems if we're going to all these lengths that we're going to have insurers reporting, why would we want to have pieces of information that are not included in that report? So that would be a question that I have.
Does anyone in the group have any response to that? The reporting rules were not my area of expertise. They were before my time, and I don't see Cassie or Tasha on the call.
I can speak to that a little bit.
There was Cassie.
There are, I think, 13 different NQTLs that we're required to go through the 5-step analysis on. One of those NQTLs is our medical management standards, including medical necessity and experimental and investigational. So that kind of Melissa, what you were just mentioning should be included in a carrier's analysis of their medical necessity standards.
Thank you.
And real quickly, I'll jump in with regard to the reporting requirements. I think I caveated it several times of we were establishing the reporting requirements for the first time, and if we need to adjust those, we're happy to do so, in particular in light of these conversations, or in light of going through our first year and realizing we need to collect different data or ask for different questions. So I don't think we're set in stone with what we put into rule, and are happy to get that feedback, and we'll internally be looking at what we received as well, and seeing if there are things that we need to update with regard to the reporting to monitor compliance. I know that that's like not a sufficient answer, but yeah, we're open to changing those reporting rules if we need to.
Thanks, Cassie. Right, Bennett, I see your hand is still up. Is that from last time, or do you have something new to add?
No, that was from last time, sorry.
It's okay. All right, so if there's not anything else, we'll move on to number 11. This integrates statutory language around level of care placement decisions and how they are authorized. Does anybody have any questions or comments about this section? Right, hearing none. If you scroll down, the next addition is to number 12. This adds language regarding the education program required by 3046. I did have a question on A. It says the training must be presented by nonprofit clinical associations. The statute does allow for other entities authorized by the department to conduct the training. So are there other entities we should add here?
I would just say that I think some of those trainings are offered actually by other groups that are authorized by the nonprofit association. So for example, I think Deerfield Associates they're the ones who license the Locus and CalLocus. And I think that they're the ones who provide a lot of that training. So language might need to be a little bit more flexible there.
Thank you. Is there anything else that's missing from this piece on the formal education program or anything that needs to be adjusted? Melissa.
Yeah, we just had one question about the part really 12B that when a provider or an enrollee requests medical necessity criteria or utilization management criteria, that as it's written, it's not made explicit that the insurer must provide information that criteria is not applied any more stringently to behavioral health than to medical surgical. And so the question that I have is how are behavioral health consumers and their providers able to know whether the UM practices applied to them are also being applied equivalently, and wondering if there's language that could be added there to that insurers have to specify that when they are asked to release that information.
Thank you for that. There is the last rule, what is it on this section that we updated, which is the 1408 rule. That's the required disclosures. That's where we added language about all of the disclosures that are required as a result of 1346. And we will hopefully today get to that section later to determine whether that's sufficient or it needs to be added to later parts of the rule. All right, and Rachel.
Thanks. Apologies, I had to step out because I spilled water, but so if you covered this, apologies. But I just wanted to note that the bill does say, or let's see, what's the specific language? Or
other entities
authorized by the division, specifically because I think there was a recognition that there are other entities who are sort of do provide the trainings on behalf of the nonprofits associations. So I think that is fine.
Yes, thank you. And there was a request to make this a little more flexible because there are people who are authorized by the nonprofits to give those trainings. So we will do that.
Great, thanks.
And Gary.
Hey, Brooke, so is there what may be helpful is if the division can post a list of those associations, just so we're aware of it. And, if we can on the cost of each association, we can work with them that way.
Right.
But that may be helpful if you guys can just make it a publicly available one.
Yeah, I can certainly look into that.
Thank you.
All right, any other questions about this section? All right, so we'll move on to number 13, and this prohibits insurers from requiring specific billing codes or restricting reimbursement paid for particular billing codes. And this was already in statute and is being codified here. Any questions on this section? Gary, I see your hand is up. Is that a question here or was that from previously?
Previously, sorry.
Okay. All right, so moving on to number 14. This outlines what the rule does not prohibit or require, and this is in line with statutory language. Any questions about this section? And then the changes to 15 and 16 are really just language changes. In 15, changing mental or nervous condition to behavioral health condition and indicating that this also applies to an individual health benefit plan. And in 16, changing mental or nervous condition to behavioral health condition and crossing out chemical dependency. So any questions on this? Okay, so we'll move on to the 1407 rule. This is a rule regarding prohibited exclusions, and all of the changes in this rule are really changing mental or nervous condition to behavioral health condition. There were no other changes to this rule. And then moving on to 1408, this is the last part of these rules that we modified. And like I said before, this is the required disclosures section. And the changes are in number 2. This was added to try to account for all of the required disclosures in 3046. And so my question really is this sufficient? Do we need to add additional language here or to other sections of the rule to show what is required? Melissa.
Yeah, I thank you very much for pointing this out, because I think you were right about that this could be a good place to add some language about insurers being able to provide us or being required to provide some sort of information about whether their criteria are being applied in parity, because one of our big concerns are some of the utilization management procedures being applied more stringently to behavioral health. And so if you know, it would be helpful to have the information on how it's being applied to medical surgical in some way or another.
Are you asking the group to kind of provide some kind of answer for you about how it's being applied right now, Melissa?
No, I think that, I think in our feedback on May 2nd, we had put something in about wanting a little bit more information, because we just don't feel like it's sufficient to make a request and to find out how, it's just incomplete. There's no parity information. We want to know that whatever is being applied to us is also being applied to medical surgical, and would like to see that as part of the information that's released. I mean, if because that's really what this bill is requiring. So it just seems like it's incomplete to not have some information about that.
Right. Thanks, Melissa. I'll go back and review your May 2nd comments. All right, and I think I saw Dan and then Jennifer and then Chris. So why don't we start with Dan?
The feds provide a lot of detailed guidance and requirements related to exactly what Melissa is asking for. And so I would just suggest that if anything is added here related to that, that it be consistent with the federal guidelines, and also that the statute, that the division is careful to review what statutory authority might inform those rules or those additions to this rule.
Thank you, Dan. All right, I think I said Jennifer next.
Just reiterating what Dan said, the federal standards provide extensive detail on this, and so consistency would be key. But really, everything Melissa's asking for, there really is already a process for this, and the annual NQTL Parity Compliance Assessment provides that. So again, let's let the work that we're already doing take place before we're jumping to conclusions that there are gaps.
Thank you, Jennifer. And then Chris.
Yeah, so I think, and hopefully not dredging up the distinction between level of placement and other criteria, but this is where our comments on the other criteria piece, I think, come into play, which is as part of those negotiations in granting that flexibility, there was a public disclosure piece on the use, what those other criteria are. But there was an exception, right, a copyright exception. Mm-hmm. And how do you arbitrate if that is applied? What does a plan member or a member of the public, how do they appeal that? There's hopefully some process to determine if that claim is legitimate. Because the whole idea of those negotiations is that there needs to be some monitoring or ability to monitor whether those criteria meet the generally accepted standards of care. And if those criteria are hidden behind copyright exception and there's no way to arbitrate that or no way to bring to the division's notice that, you know, these may not be in compliance, right? That's that whole area why we feel it's important to have an appeal process or some way to bring this to the division's attention.
Is there currently an appeals process when there's a copyright claim on materials?
I would probably, to my knowledge, there's not a requirement federally or in state that requires a plan to disclose its entire criteria. I think, and others jump in, my understanding is the only time they are required to disclose criteria specifically used is when they do a denial. And that's, but in the name of sort of the granting of the flexibility around these criteria in that area, the trade-off that we negotiated was, okay, allow us to look at that so that we can make that evaluation. And if we disagree that these are meeting generally accepted standards of care, we can bring that to the attention. In those negotiations, there was a concern that copyright might come into play. And then so my understanding is this is sort of new territory.
Okay, thank you. And I see Rachel and Dan, so we'll go to Rachel.
Thanks. I just wanted to build on all the comments and say, I think one of the frustrations on just relying on sort of the carrier report to DCBS is I'm assuming those won't be made specifically publicly available to consumers. And with DCBS being a complaint-driven process, I would imagine having at least some clarity for consumers and providers that the criteria is being applied no more stringently also alleviates the potential for a bunch of complaints filed against with the division. So I think if it's possible to provide some, I hate the word transparency, but transparency, certainty, clarity to enrollees and providers around this specific issue, it might be helpful in the long run with the assumption that folks are doing what they're supposed to be doing and aren't applying them more stringently.
Thanks, Rachel. And Dan.
Thanks. Yeah, I just wanted to come back to the copyright issue a little bit. So if the, and address particularly Chris's concern about hiding behind it, because that certainly wasn't the intent in putting that in there. And just to build on what Chris said a little bit, it would not, that copyright sort of exemption would not apply in the case where a carrier, so if a carrier denies something based on a criteria, then the member has the right to get those criteria. And our copyrights that were in mind in creating that, for example, with MCG or with Interqual, that's a use that's allowed within our agreements with those copyright holders. So we are allowed and we are required to give those criteria to a member if we, or the member's representative, if we have issued a denial based on those criteria. And so I think that's where that transparency comes in and is provided, is that if it's used to deny care, you get to see it. And if they do a complaint to the division, or if it goes to an IRO, those entities get to see it. That's all within the fair use that we're allowed to do within those copyrights. It's just what the copyright doesn't allow us to do is publish their entire criteria set to the world, because that's their intellectual property. But we license it for using in these scenarios, and current agreements and law provides for the transparency that's required when that's actually used to deny care.
Thanks for that clarification, Dan. So any other comments on this section? Melissa.
I just want to provide the example that we've been using throughout our written comments, just as something to illustrate this section. We have the practices that are occurring around Oregon by Change Healthcare, where they are monitoring usage of CPT code 90837 and sending letters to providers. And they're not denying care. They're not specifically asking a provider to do something different, but they are putting pressure on providers by saying that they are being monitored. And, that would be something that I, as a provider, would want to request information on. And I would want to know, are those same procedures being used for medical surgical? Is this being applied in Parity? So that would be a concrete example that I'd like to give.
All right. Thanks, Melissa. Any other questions or comments? All right, hearing none, we have made it through the whole rule set, which is amazing. So now if we can go all the way up to the top, I know you just exited it, I'm sorry. We're going to go through the changes that we made since the last RAC, which are also included on that same document, Karen.
Okay.
There we go. All right, so the first change was made to this 0012 rule, and that was in 2B. We removed information on the base benchmark plan. We talked about that at the last RAC. That was a drafting error, and so that was removed. And then in 3, if you scroll down, 3D and F, I believe we added language regarding the current version of the DSM. And I have that as the Diagnostic and Statistical Manual of Mental Disorders, 5th edition text revision. So is that the correct version? Is that the current version? Can any of the providers on the line confirm that the DSM-5 TR, is that the current version? Yes, okay, all right. And then those were all the changes that were made to this particular rule set. Are there any questions about those changes? All right, so scrolling down, we did not make any changes to the 1403 rule. There were none requested either in comments or at the last RAC meeting, so that remains the same as the last draft that you saw. There were some changes made to the 1404 rule. So if we keep scrolling. All right, so the first change here was in 1A, where we added the DSM 5TR and also the ICD 11. So again, I have the ICD 11 as the current version. Can anyone confirm that that's the correct version that should be listed here? All right, I'm going to assume that's the correct version because that's what I saw online. So if it is not, you can provide your comments to me. Let's see, there was a request here to look at bulletins from 2014 around mental health parity to see if they align with 3046. And around there were questions around the version of the DSM that was used in old bulletins. I did take a look at those. There are 2 bulletins from 2014 that relate to mental health parity. There is one on mental health parity, and then there's also one on autism spectrum disorder and applied behavioral analysis therapy. The information on the DSM is found in the Mental Health Parity Bulletin, and it appears that there was a change from the DSM 4TR to the DSM 5 during the period when that bulletin was drafted. And the bulletin actually allows for insurers to use either the DSM 4TR or the DSM 5, depending on which version of the DSM was used to create for the diagnosis. So whichever version of the DSM was used for the diagnosis is the version of the DSM that is allowed under those bulletins. There are some changes that will need to be made to those bulletins based on 3046, so we'll be looking at that, but I did want to let people know that I did look into that and see if there are any questions.
I have a quick comment. Going back to the ICD version, I wasn't able to unmute myself at the moment. We're using, I think, the whole country, but if not the whole country, I think the whole state is actually using ICD-10, even though 11 is current. The industry is using 10 because it's a pretty big deal, pretty big technological lift, I think, to change from one version to another of ICD.
Okay. Thank you for that. All right, so moving on, in 1B, there was a numbering issue on the last draft, so we just updated the numbering so that it goes in order A, B. So B was updated. And then in 2, we removed the word group, if you keep scrolling down. We removed the word group as the rule applies to both group and individual plans. So those are all the changes that were made in the 1404 rule. Are there any questions? All right. So then there were some changes to the 1405 rule. Just to let you know, there were updates made throughout the rule to ensure that it applies to both group and individual plans as required by 3046. In number 1, we added, let's see, in that last sentence, we added the word qualitative limitations. I believe that it should actually be quantitative, so we will be making a change from qualitative to quantitative in the next draft. Just want to let people know that. And then 2 and 3, this is new. These were both the updating the methodology and using the same methodology were kind of smashed into one section in the last draft of the rule, and as requested by the RAC, I broke these out so that number 2 talks about how plans must use the same methodology to set reimbursement rates, and then number 3 talks about updating the methodology that's used. So it's 2 separate sections instead of 1 section. Any questions about that? All right, so moving down, the next change was in 4C. And we removed the language. I'll wait till you get there. Yeah, there we are. So we removed the language on predominantly all and substantially equal, as these tests do not apply to annual or lifetime limits. And then in 4G, we added language indicating that utilization and other clinical reviews must comply with rule and with the definition of generally accepted standards of care. Right, and if you go down to 7, we added that the citation for the rule and the statute that the section is subject to. And in 8, I just broke this out into A and B and then added, as we talked about earlier, the date that the nonprofit criteria to be utilized. So the effective date, January 1st, 2023. Any questions about that change? Gary.
Yeah, it's the same thing with this January 1st, 2023 date. It's an unknown. I don't know what, especially is going to be in place then. And I'm not sure other carriers are doing, but that just had us a little concerned is we're going to put something in rules and adopt it, and who knows what changes occur at a later point. And so, and there is no process that I'm aware that a nonprofit professional association go through is when they develop their criteria. So just want to put that out there. We had concerns with having an effective date in the future for criteria as opposed to something now where we can review it and prepare to be compliant with it.
Yeah, this was this was added as a result of the conversation at the last RAC about not having current version in the rule and having, having more specificity around that rather than just current version. And so that's why this was added here, just so people are aware. So we will look into whether that's needed.
Right. The other part is if we need to update it, do we go through rulemaking again? If there's new criteria released in 2025, do we have to come back and, update the January 1st, 2025? And that was the other thing, is just how often do we have to come back and revisit this rule in order to update if there's new criteria released? Okay.
Thanks, Gary. And I did. Go ahead.
Sorry, I was just thinking maybe we can have our cake and eat it too, because so I agree that a future date is a concern. But so if we, as of let's say May 19th, 2022, and then maybe have a safe harbor for carriers may adopt future versions as as they come out, then that would, then we wouldn't be bound by something that's outdated. We'd have the flexibility and wouldn't have to rewrite the rule every time they come out with something new.
Yeah, thank you for that suggestion. And I did see someone's hand up. Melissa.
Yeah, I actually missed this just because I didn't look carefully enough at what was crossed out. And so I saw that under 9, the very last sentence is identical to the sentence below that you had highlighted in yellow, and was just wondering, because that wasn't in the previous version. And so it looks like it was put in and then crossed out. And I just was wondering why that would be different than the section below where it was added in. and it was kept in.
Yeah, so I just wanted to make clear one more change in 8 that I didn't mention was that we changed the and to or based on reviewing 3046 and the comments from the last RAC. And then number 9, you're correct, that was added and then removed because in the rule, it's clear that the advancements in technology based on generally accepted standards of care only applies to level of care placement decisions, but not other criteria. So that's why it was removed from this section and then put down into the section that applies to level of care placement decisions.
I was referring specifically to the very last sentence. Other criteria utilized is subject to review and approval by the department or its designee, and just I don't see why that can't still be in this section. I know that is that's something that's under debate right now, but it just seems to me that if it does stay and it stays below, that it would make sense to keep it up under 9 as well.
Yeah, great. Thank you for that. So we've made it back to the section that we already reviewed today. Are there any other questions? Jennifer?
Yeah, I just want to reiterate that the bill does not give statutory authority for non-level placement of care. So it should not be in there. But also, again, it is a dangerous precedent that could open up the door for a court challenge to the entire law. So just want to reiterate that comment.
Thank you, Jennifer. And Chris?
Yeah, I think it's just a general comment in these areas that, right, so how, and I don't know this is addressed in rule, but is there a process by which in examination of criteria, because they do have to meet generally accepted standards of care, that is defined in statute, how do we bring it to the attention of the division if there's criteria being used that isn't involved level of placement, that the belief is it's not meeting the legal definition in statute of what it needs to do. And so that I would just, I don't know where that gets addressed or whether that's a process question that, you know, how does a plan member, how does a NAMI bring it to the division's attention, and how does that get examined? And that's where I think, you know, I'm sympathetic to the prior review and whether or not that's advisable given the volume of information. At the same time, we need a pathway to be able to challenge whether or not criteria is meeting the legal definition.
Thank you for that. Any other comments? All right, so we've made it through the rule review. A little bit early, actually, but I think the next on the agenda was some time for public comment. So is there anyone who has any public comment at this time? Oh, I see. I'm sorry. I see other hands. Rachel and Rick, were those new hands or were those old hands?
Sorry, very quickly, I think there was additional rule language that was sent out by Karen after this one that specifically talked to the LGBTQIA.
Thank you for that reminder. I did let Lisa know that if we got through everything, we would go through the network adequacy changes as well. So thank you. Lisa, do you want to go ahead?
Certainly. Hi, everybody. So as far as network adequacy goes, we really only received feedback and specific comment from Basic Rights Oregon and perhaps from other RAC members reiterating that there was a request in a part of the division's network adequacy rules to identify specific enrollees and groups that should be identified in rule. And so we've provided this language that was, sorry about the beeping, just a moment. It stopped. This was specific phrasing that was provided from Basic Rights Oregon RAC members. And the division has the authority to, you know, identify specific groups that should be, that insurers are addressing the needs of specific enrollee groups. So wondering if this meets the desired outcome and if there's any feedback from the RAC members. if we make this change now. And we do plan to make broader, have broader discussions about network adequacy in general and make sure it has parity for both mental health or behavioral health and medical surgical. But this is just the first step in our process of updating our network adequacy rules. I see a hand up. Is Laura? You want to go ahead and comment?
Thanks, Lisa. Yeah, I'm the representative from Basic Rights Oregon on the RAC, and just really appreciative of you all adding this language in there. For context, the specific phrasing is what we have seen used in statutes. It's sometimes the way that we refer to the community has changed over time. This is kind of the most inclusive and accurate definition that we've been able to come up with that Legislative Council has also been using. So wanted it to be consistent with that, and really grateful to see it included here.
Thank you very much. And thank you for that clarification and that background. Gary?
Yeah, just on this one, Lisa, it's one where, it's great we add this, but it's difficult to get the information. If you're looking at our efforts, I think it's going to be it's a little bit challenging to try and explain this to you guys and if it's sufficient or not. We looked at this at Pacific Source, and getting responses is sometimes challenging, but from the providers, we can always say that we reach out, but I'm not sure what we're trying to do here is specifically call out a company or what we're addressing. I'm just a little confused by what's going on. Can you give me a little bit more? You're looking at our efforts. Is it just what we're doing? Is it the responses we're getting back? Is it the conclusions or end game that's being accomplished with our outreach? What is it exactly?
Well, I will probably ask if Tasha or others of the division that review network adequacy are on the call today. But I think it's to shine a light on a group that has been historically underserved, and there's a need for adequate providers to meet the needs of this population. So we want it to just be called out specifically, and just realize there are challenges and that there's going to be ongoing efforts to build an adequate network. That's the goal here, I think. But if anyone else wants to comment, back me up on that. I would appreciate it. Cassie?
Hey, Gary, everyone else. So I think part of this is going to be, part of the evaluation around, I think we've had several conversations around diversity, equity, and inclusion, particularly on the insurance side, and that does relate to network adequacy. So this is an acknowledgement that this will be probably part of some of those reporting requirements in the future. We are doing some big network adequacy work on the other side, but making sure that that's captured in how we evaluate networks or how services are provided for these specific communities, and in particular the LGBTQIA+ community as well. And I see some hands. Rachel?
Thanks. I just I didn't know if it would be helpful to hear from the folks who worked to pass the bill. But ultimately, this is, aspirational language. The goal of the bill is to create a situation where carriers have to build out their networks. And our hope is that by specifically calling out these populations, that there is an intention that when you're thinking about growing your networks, that you're intentionally reaching out to providers who cater to these needs. So I think there is a recognition that you all are going to document your efforts, and those efforts will probably reflect whether or not you're getting responses from your providers, but also that there's hope that you're also going to document your efforts to get more providers who cater to these specific needs.
Thank you.
Very
Jen?
helpful.
Yeah, I'm actually in agreement with a lot of what's being said. And for those of us who are eager to network and contract with, or build our networks and contract with providers who offer services that relate to the LGBTQ+ community, there's not a requirement on the provider side to indicate what services they offer. And I just want to kind of level set a little bit. We had a bit of confusion in Washington because we're required, there was going to be a requirement in our provider online portals to indicate that. But again, like, there's going to be a provider who offers services to everyone, but that includes the LGBTQ plus community, but they don't specifically state it that way. So, you know, I'm interested in hearing more on how we can work together on figuring out what providers do offer services that are catered to that community, but also identified as such. So I just kind of want to like bring that up, but please understand that many of us are eager to build our networks on this one.
Rachel?
Thanks. I just also wanted to acknowledge throughout all of this that 3046 is the start of the conversation. It is not the end. I think we all worked on this bill acknowledging that it was not going to solve our problems, not because carriers are the source of our problems. You know, so I think that a lot of this conversation is sort of getting a lay of the land and figuring out what's out there. We all know there's a provider shortage, but we also know that all the providers aren't on panels for specific reasons. So I just want you to know that at least from me, that there was a commitment that this is an ongoing discussion. And if additional changes need to be made down the road to make sure that we're adequately serving a population, let's have those conversations.
Laura?
Thanks. And thank you, Rachel, for the context and kind of, I totally agree with your, with the way that you've described kind of the intention behind this. And, you know, for the carriers, Basic Rights Oregon is an advocacy organization, but we do a lot of, you know, we get a lot of intakes from folks that reach out to organization from all over the state who are, you know, dealing with any number of issues related to their gender identity or sexual orientation. If there's ever anything that Basic Rights Oregon can do in terms of, you know, outreach or education, or I'm not sure what that would look like, but I know that, you know, the behavioral health of the LGBTQIA+ community is, it's something that's, it's pretty scary right now, I think, and folks are, I think we're trying to do whatever we can to make sure that people, especially LGBTQIA+ youth in rural areas, are getting the help that they need. And you know, I appreciate Jen's comments. I think this is something that we all need to think about and look at and work on. And the area, you know, we're in obviously we've banned conversion therapy in Oregon not that long ago. So we've come quite a ways in this area in a short amount of time. And I think that figuring out kind of what it means for a behavioral health practitioner to provide services that are responsive to the needs of this community is something that's evolving. I know that some of the resources that we refer out to folks, providers will self-identify that this is an area that they particularly specialize in or want to work with this population. I think our folks find that really useful, but appreciate the comment that they're not necessarily required to indicate that. So it might be difficult to figure out if you're meeting this requirement or not. So it's definitely the intention behind it, and happy to do whatever we can to be helpful.
Thank you very much, everyone, for your comments on this, and it's a good discussion. As far as network adequacy goes, if there's any other additional comments or discussion or any things that you'd like to raise today, it's appreciated, and we have a little time to discuss that. And also just stopping there, if now as we don't have enough time or you need more time to think about it, we want to encourage you to keep thinking about this topic of network adequacy, reviewing the documents, the crosswalk that I provided to the RAC previously. And we welcome comments, and we'll continue to have further discussions about, you know, which direction we're headed on improving network adequacy. Cassie Brooke, any other comments you'd like to make on the topic? Or Tasha?
Just really quickly, just again, I think this has been said several times in this RAC, But the division is working on kind of some big work around network adequacy. So don't think that this is like the only thing we're going to do. There's a pretty significant body of work that we're working on internally, and there'll be a lot more conversations moving forward that are sort of outside of the context of just mental health parity and looking at network adequacy overall. So stay tuned for more network adequacy fun ahead in the future. Antoinette?
Yeah, just a really quick question. So if this is adopted, I'm assuming it will be for the 2023 report?
We would need to review it, what the requirements are for the 2023 report and see where this fits in.
Okay.
And we'll be in touch if there are changes that would be addressed specifically by this language for the 2023 report.
Okay. Thank you.
All right, so if there are no more questions, then now we have made it through all of the draft rule set. I'm seeing Rick, I think you're here for public comment, so I'll open it up for public comment. And Rick, go ahead.
Thanks, Brooke. I'm Rick Blackwell at Pacific Source. I wanted to I'll address I got a number of things I wanted to throw out in terms of public comment. Let me address network adequacy first. Like Jen, we too are trying to build networks of providers that meet the needs of the community. Especially on the Oregon Health Plan side, though, we've been running into complications with how much providers actually want to share about the kinds of cultural competencies that they're able to provide or willing to even disclose certain demographic information about themselves. This is leading to a situation where OHA is actually looking at perhaps changes to provider directory rules that that would, I think, bears on this network adequacy discussion. So I think maybe we should monitor the OHA work that's happening around provider directory, just to inform how this might play out if carriers are going to be asked to include this within I think this is NCQA standards, right? The rules around network adequacy. Yeah. So throw that out there as just some context, additional context for DFR to consider. The bulk of what I want to talk about, though, is in section 10, or I guess subsection 10 of Rule 1404. I just have to reiterate that, there isn't really any mechanism for DFR to review criteria or a designee. If the legislature wanted to say so, they certainly should have and could have done so. But that's not a it's not a legal. I don't know, I guess a legal ability for DFR to undertake. I also think in sub 10, the division's trying to square this legislative command of you have to use the most recent criteria that's produced by nonprofit associations with this body of constitutional law that suggests that the agencies can't delegate authority to outside actors. And so I don't think the rules quite get there in terms of providing enough specificity as to what placement of care criteria actually are. Just saying locus, cal locus doesn't necessarily tell you which version and where to access the standard. I think the danger here without a lot more specificity is if whenever these changes, if the associations make a change outside of the rule process, the rule suggests that automatically becomes the law of the land. I think that would be a problem for us all. And so I don't believe that's really was the intent of either the bill or the rules. And so I would just call for more specificity in those. Noting that a specialty might be effective as of January 1st, 2023 is helpful, but I still would argue that more specificity is needed in those references. And I think, just a couple more things. I can't imagine DFR has the capacity to actually review the criteria, and I'm uncertain what recourse there would be if the review turns out not to be correct, if that's what happens. Not saying that DFR would get it wrong, but sometimes there are disagreements in the law, so that just happens. It would be curious to know if nonprofits have the capacity to train carriers as well. I think we need to think about that in the future. I just please take care not to inadvertently change requirements when you're mirroring statute into rule. I mean, a word change could mean a lot. And so we just gotta, I mean, if we're gonna mirror statute, we have to mirror statute exact. And then I think in terms of copyrights, the copyright issue is really gonna come up if you adopt a standard into rule. And then it's a question of how do you balance the copyrights holder with the need for everyone to understand what the legal requirement is now that you've adopted copyrighted material. So those are all of my comments. Thank you very much. Be happy to follow up as necessary.
Thanks, Rick. Appreciate your comments. And I see David.
Hi, thanks for the opportunity to comment. David Shilcutt. I work with mostly on, well, I've worked with a number of entities that are on all sides of this issue. Most of my present work is with payers around the country. A lot at the federal level, and I appreciate the opportunity to offer some federal perspective on how some of these requirements are playing out around the country. I apologize to be jumping in at midstream. These proposed rules were just recently brought to my attention, but I think it might be helpful to note to set expectations about what can be accomplished through regulation and enforcement on parity in Oregon. So I appreciate the desire to preempt or prohibit any sorts of parity violations, but the fact of the matter is that parity requires comparability of everything. And current enforcement at the federal level and in many states is attempting to try to ensure comparability of everything all the time. I spend a lot of time, almost all of my practice really right now is on parity. And the analyses that we develop are generally dozens of pages long, depending on the company. I spend, probably 30 to 50 hours per NQTL type with many companies trying to document comparability. And I'm going to be really frank and say very little ever changes in the course of that work. Where change happens is where there's a very specifically identified concern and the requirements apply really specifically. In some states, there are state regulations that have been written very specifically that facilitate enforcement. But where we're just looking at everything, it's very difficult to for a regulator to push a carrier to the point where they provide the level of specificity that would even highlight that an issue exists, let alone be able to force anybody to change something. And I'm comfortable saying that because my clients that I work with are always happy to make changes where we identify something that needs to change. But the ROI for the efforts that we're putting into this right now is extremely low. For medical necessity, because that's been a lot of the topic of conversation today, I don't think it's feasible to try to ensure from a regulatory enforcement perspective that every clinical policy implemented by a carrier adheres to generally accepted standards of care. The types of sources that are being identified as generally accepted standards of care are developed by providers for providers. They're not developed for utilization management purposes, and it's often a square peg in a round hole to try to adapt a treatment guideline for utilization management purposes. In any case, it's an extremely technical clinical determination about whether any given guideline adheres to clinically generally accepted standards of care. Most carriers are using nationally recognized vendors for most coverage policies, like Interqual and MCG are the big ones, but there's some others out there, Evicor and others that have a smaller market share, sometimes devoted to specific conditions. It would be extremely inefficient to try to require carriers to analyze policy by policy, service by service, the Interqual guidelines, when they're all using, or MTG or whatever, they're all using basically the same ones. And if there's a concern about whether those national vendors generally whether their guidelines adhere to the generally accepted standards of care. The only way you're going to get change is if you identify what are those problems. Like, what are the specific guidelines that are causing concern and that are believed to not adhere to generally accepted standards of care? From at a high level, if you look at the policies and procedures from those vendors, as I have, they're all going to say all the things that you want to hear, right? About, I mean, they have very rigorous processes. They are deeply, I mean, they're much more up to date than the ASAM criteria, for example, which were last updated in 2013. You know, Interqual and MCG are constantly reacting to the new evidence, and so adherence to the evidence, and they can cite, you know, reams of evidence. Now, if there's a concern about whether they are in fact adhering to that evidence, like I said, it's not I'm an attorney. You know, I'm not a clinician, and I can't make that determination. But there are reasonable differences of opinion. You know, none of those. I mean, if you listen to the ASAM criteria work group discussions, like within the provider community, there's huge variability of opinion about. You know, these are highly contested processes on the provider side about how to determine these kinds of things. When you look at the ASAM statement about urine drug testing, for example, very political, and it underwent really significant changes over time and ended up saying almost nothing that is useful to payers about what is the right frequency of testing for urine drug testing. You know, there's tons of fraud. At the same time, patients need it. Just an example to show that, like, this is a very complex area, and it's not something that payers are going to be able to easily document and submit like a 3-page, 5-page, whatever number of page analysis and show you that comprehensively across the board, all of their clinical policies adhere to generally accepted standards of care.
And I don't mean to cut you off, David, but we only have about a minute left. So if you have a last thought, go ahead and say it. And if there are additional comments, you're more than welcome to send additional comments to myself for review.
I appreciated Melissa's comment about the concerns about psychotherapy codes, and I think that's a really good example. There's obvious comparability between office visit, you know, the E&M codes and those higher level codes for E&M and psychotherapy. That's an example of the type of issue that you could design reporting and enforcement to say, like, is this an issue, and show us the comparability. So, I mean, I think that all of my clients would be able to do that. I think you will find that it's comparable, but that's an example of something that's targeted. It can be well defined, and you can determine comparability.
Okay. Thank you, David. All right, so any other comments? We only have like a minute left, I believe. Not seeing any, so the next RAC is scheduled for Wednesday, June 22nd from 1:30 to 3. If you have any additional comments, please provide them to me by June 2nd. That gives you 2 weeks. We'll be going back and having an internal meeting to discuss some of the comments and suggestions for changes to the draft. I think we'll present a new draft of the rules at the next meeting, and there may be some additional time. I believe there was a request to have a discussion around how providers can use the nonprofit association criteria and guidelines. Are there any additional requests for agenda items for the next RAC? All right, hearing none. So thank you, everyone. This was a great conversation. Really appreciate your time today, and I'll see you next month.
Thank you.
Thank you.
Thank you.